Podcast is now starting. All attendees are in listen-only mode.
Hello and Happy New Year and welcome to the January 2019 Pre-Hospital Care Research Forum Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by David Page and Dr. Tony Fernandez. And today we were reviewing the article entitled Death by Suicide, the EMS Profession Compared to the General Public. This was published in 2018 in Pre-Hospital Emergency Care. Now, this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World, and this article is called Journal Watch, Examining the Latest in EMS Evidence. We encourage listeners to check out this article in emsworld.com under the category of education and training. So thank you all for joining us today on this very important topic. Let's begin, and we really want to remind you, we'd love to hear from you, especially on this topic. You can use the chat feature on your screen to type in questions and comments, and we're going to bring those into the conversation as we go. So according to the Centers for Disease Control in the United States, suicide rates have increased in nearly every state from 1999 to 2016. And, despite increases in funding to address this major public health issue, suicide rates are still on the rise. And suicide is rarely caused by any single factor. In fact, many people who die by suicide aren't even known to have a diagnosed mental health condition at the time of death. There are other problems that often contribute to suicide, and we know that job-related stress may be one of those. In fact, risk is not equal across occupations. We know that there's an increased risk among law enforcement officers and public safety personnel. But what about EMTs? So national survey data suggests that EMTs have a greater incidence. In fact, the article cites a tenfold higher incidence of suicidal thoughts and attempts. And both of these factors are associated with suicide completion. But the data on completed EMT suicide are scarce. So the objective of this study then was going to assess the proportion of deaths attributed to suicide among EMS professionals compared to non-EMS professionals, and this is in the state of Arizona. So I'm going to bring in Dr. Tony Fernandez to help us with the methods of this particular study. Tony?
Hey, good afternoon, everyone. Thanks for joining us. I think this is a really important study. So let's talk about a little bit of what they did. This was a retrospective case control study. Essentially they had their group that they were looking into. They found EMTs. Case control essentially is they had their cases who were folks who committed suicide, and their controls were the folks who did not. And this was a retrospective study. We'll go into that a little bit deeper in a minute. The study period was from January 1st, 2009 to December 31st, 2015. And again, they used the Arizona Vital Statistics Information Management System to pull out this information. This is a really unique study in that they were able to pull this directly out of one database for the entire state. So this database captures all data on deaths that occurred in Arizona, as well as deaths for Arizona residents that occurred outside of the state. So the data then they're provided by funeral directors, medical examiners, and or the medical facilities. They have demographic data such as age, gender, race, and ethnicity. They also have, luckily for the authors and for all of us who find this information interesting, they had data on the individual's occupation and the specific cause of death, which made this work possible. So what the authors are able to do, yes, please.
Can I just ask you a quick question about that? Do you know, I'm not sure if you know anything about these types of databases in terms of how they collect that, how they collect and categorize occupational data?
So it's interesting. This that's really hard to do. I don't actually know for this how Arizona gets it, but I do know that it's a free text field. So there's a wide range of actual occupations that they can include where they actually obtained that information, that wasn't in the study, and I'm not as familiar with this data set as to be able to answer that question.
Yeah, it's interesting. I mean, I found this whole idea of a database, just even knowing that something like this exists, and to the detail that they described in the study, very interesting for people who are doing research to know that there's a database like this. Also, that it's mandated by Arizona law, and then it's regulated. So that kind of, I think, may add some strength to the validity of some of the data.
Oh yeah, absolutely. I think that using it in this is a pretty novel way, I would imagine, to use this data set. So having the resources and then having some creativity, I think, really helps.
Yeah.
So, more about the data set.
Sorry, I interrupted you.
No, no worries at all. More about the data set. So I believe I was saying that they collect demographic data. So they had the occupation and the cause of death. So they categorized profession as EMS professionals or non-EMS professionals. And again, as we just mentioned, this was a free text field, which makes this categorization quite complicated, but to go through. But let's they were able to find emergency medical technicians, paramedics, EMTs. They also included fireman and firefighter as EMS professionals. And that made up the category of the EMS category. And then everyone else was included in the non-EMS professions category. Now, one thing to keep in mind is anytime you're working with free text, there's a whole bunch of different ways that you'll find out that people can spell paramedic or emergency medical technician. So being really careful in selecting these data are important, and it seems like the authors did a good job there.
Yeah, and if you look at Appendix 1, there's all the that's the online supplement that describes all of these details, because like you said, you can describe it in a number of ways. And in fact, we had a comment that was just posted from Narina Stepanovsky from an EMT. Hi, Narina. When you say EMTs, are you referring to all EMS personnel or just EMTs? And I think I said NAEMT, and I meant NANEMC, National Association of EMS Educators.
They were trying to the goal was to try and capture all EMS professionals, and in doing that they looked for the specific word emergency medical technicians or words. They looked for the specific words paramedic, and then they looked specifically for EMT. And then they had a whole list in the appendix of different spelling variations and the like of what they looked for. But their goal was to capture all EMS professionals.
Yeah.
And Megan, just this is Dave Page, and I just wanted to pipe in and say that Dr. Bobrow, who's one of our authors for this particular paper, has joined us, and he is on the line. We're trying to get him unmuted, and when he's able to make a comment, I think we'll include him into this. So.
That'd be great.
That would be really helpful in understanding the data set and how it's required and the like. So let's continue to plow through these methods. So there's more issues with free text fields. I really want to get the message across to everyone listening of how difficult it is and how important the work that the authors did here is. With free text fields, not only do you have to deal with spelling errors, but you also have to deal with making some decisions when the field is left blank or the authors are really unsure of if the occupation required an EMS certification. So they did some follow-up investigation if there was an occupation in there that they thought that might be related to EMS. They did some follow-up investigation to see if they can include those folks in that category. But if following the investigation they couldn't determine if an EMS certification was required, they listed those folks as non-EMS professionals. And they also, in this data set, they were able to categorize the cause of death. So they dichotomized that, or they cut that into two categories, which was suicide and then all other causes.
Yeah, this is an interesting thing too, Tony, because they discussed the ICD-10 revision and the classifications of codes, and then the other the types of codes called E-codes. And if anybody out there is at a college and you have a coding program, that's a fascinating thing to look at. It's just a complete rich source of information about the patient. So they used the standardized data codes.
Yeah, absolutely, and that is ideal. If you have the option of using standardized codes or free text, folks listening, you'd want to use standardized codes every time. But the authors they admirably had to work with both types of data here, and were able to pull out some interesting information.
Okay, so tell us what do you do with all of this? We were talking about this a little bit before we came on, and I was saying to Tony, God, how do you even begin to say how do I want to look at this population? Am I looking at just those who completed suicide and then comparing between EMTs and non-EMTs? Do I look at the total deaths and I go by age? The authors later on will talk about the couple of different ways we can slice this, but tell us how they did. And we used a 7-year data set? Yeah.
So the time period, or the study period, excuse me, was from January 1st, 2009 to December 31st, 2015, which is a wealth of data to dig into. And initially what they did was they did some descriptive statistics. They compared demographics and methods of suicide among EMS professionals and non-EMS professionals. They used chi-squared tests to do this, and although that sounds complicated, that's just a statistical test of proportion. So in short, if you're comparing 50% to 100%, you want to know, you might think that or let's say 50% to let's say 80% to 100%, you may want to know, you may think right off the bat that 100% is better. However, if the person who has 100% only had 2 attempts, and the person who had 80% had 1,000 attempts, you may, that initial thought that one was better may not be true. So the statistical tests help to adjust for that somewhat. And in this case, they used a chi-squared test. They also wanted to calculate the odds of suicide. So they performed logistic regression modeling to determine if the odds of suicide were different among EMS professionals and non-EMS professionals. And they called this the mortality odds ratio. And we'll see odds ratios quite frequently in medical literature. And logistic regression is a great tool to be able to not only calculate a crude odds ratio, or an odds ratio essentially looking at the factors with blinders on and not taking into account covariates or confounders. But you can also run logistic regression models where you can adjust for things like age, gender, race, and other demographics that may confound the relationships or have some interactions. So they did both. They did what we call univariate and multivariable logistic regression modeling to come up with a mortality odds ratio. So they worked on some the statistical approach, I think, was definitely adequate, and we were able to use it to interpret these data.
Okay, great. Do you think we could move on to the table 1 slide then, and let's take a look at some of this?
Yeah.
I'm going to have a question for you later about about how to explain this to somebody, and maybe I'll just bring it up now, explaining to, we're obviously going to make the point here after reading this article. And if you've had a chance to read Tony's article, if you haven't, please look it up, Journal Watch EMS World, on this article. Really, really important piece of work. And you think about, okay, if we are going to make the case to policymakers, local funding agencies, to make the point about need for resources, then how do we take this and explain it to policymakers without having to use things like adjusted odds ratios and mortality odds ratios, which is just going to fly right over their heads?
Well,
Yeah,
it's a huge point.
Even though it sounds difficult in odds ratio, the great part about an odds ratio is the interpretation is relatively simplistic. So for an odds ratio, if you have an odds ratio of 1, then there is no difference. If your odds ratio is greater than 1, then there's a difference, or if it's then you're more likely to see that event. If your odds ratio is less than 1, then you're less likely to see that event. So it really just centers around 1. So I wouldn't suggest trying to turn policymakers into statisticians and trying to explain to them how you run the tests, but you certainly can give them information on how to interpret the results. And I think that's really where the rubber meets the road and how you can turn research into practice.
I love that you're that smart. I'm gonna side on the. I'm gonna land on the side of, oh my goodness. Already we had some issues with inclusion because the population we're studying, and other studies have had the same problem, is a little bit difficult to define. If you're a firefighter and an EMT and you committed suicide, is that because you were a firefighter or because you're an EMT? Was it after an EMS call? So, and who do you define as an EMS provider in when you're looking through these, whether it's coroner reports or databases that may or may not indicate that, you know, their primary occupation was an architect, but they worked on the ambulance on the weekends and were a volunteer. And so the population that we're studying is extremely difficult to pin down, and that makes the results that much more difficult to explain to a policymaker.
Yeah, and I think that's a great point, Dave. I think that the authors really did a good job later on when we talk about their limitations and being upfront and saying, you know, it had to be in there. It had to be written to the specifications that they designed for their definition of an EMS professional. I think that some of the things we'd want to take into consideration are how the EMS system in this state works. There are some states where it may not make a lot of sense to include firefighters and EMS professionals if there aren't many fire-based EMS systems in that state. There are some states where it's almost entirely fire-based, and it may make complete sense, and then there's anything in between. So the one thing that I think everyone needs to keep in mind with all research is there are always limitations, and nothing will be perfect. So you try and do the best you can with the data that are available, and I think these authors went a good way in succeeding on that.
And in some ways, it's kind of a moot point, or it's a who cares if you're an EMT and you're exposed to a lot of suicides, or whether you work for whoever you work for. It may not matter. Although I can completely see Dave's point. There is a big difference at times. And the other thing, I guess, is they talked about including nurses on helicopters. They didn't mention that in the methods. They mentioned it in the discussion or in the limitations, I believe.
Yes, yeah, they did. So they did.
What about retirees? What if somebody retired? Is their occupation included? Because they've had the same exposures, right? Whether, in fact, they may have had more. They're retired and they've had 30 years of experience.
And the authors did a good job of stating this. It had to be included in the data set. It had to be written. So for retirees and for volunteers, it may not be written in their occupation, and you may not know. So they could have missed those folks, and likely they did miss some. But what most good research does is it kind of opens our eyes to an issue, and kind of spurs on future research. And I think that this is going to be hard to do in a lot of other states, what these authors did. to have an all-encompassing data set like they do, but we were able to tease out some good information here.
Great. So walk us through this.
Yeah, so during the study period, there were 350,998 total deaths. And among the total deaths, about 1,205 were categorized as EMS professionals, based on the categories that we just discussed. So that means that 349,739 were categorized as non-EMS professionals. And then they looked at the percentage of suicide deaths among each category. And among non-EMS professionals, it was 2.2%. Among EMS professionals, it was 5.2%. So that's an important difference right there. They also they adjusted for gender, age, race, and ethnicity. And after adjustment, EMS professionals continued to have increased odds of suicide when compared to non-EMS professionals. So we talked a little bit about how to interpret odds ratios. If it's above 1, it's more likely. If it's less than 1, it's less likely. Likely is an easier word to understand than you have increased odds. But the test really shows if your odds are increased or decreased. But for those of you, just for all intents and purposes, let's think of it as likely for now. The odds ratio was 1.39. That's a pretty impressive odds ratio. Usually in most medical literature, if you see things around 2, that's really, really impressive. So 1.39 shows that there's certainly an important difference there. And the confidence interval was 1.06 to 1.82.
Let me ask you a quick question here. Is there ever a problem when you, and if so, how does it affect a data set, when you have two populations you're comparing and you have an enormous difference in the number in each like this? You know, you have almost 350,000 in one and 1,200 in another. Is there ever an issue?
There could be. There certainly could be, but not so much of a difference that you're worried about, but you're worried about how many you have in each population. So, for instance, if you had 30 individuals or less in one of the populations, you really wouldn't have enough power in the test to say if there's a difference or not. You're not so much worried about, well, there's 1,000 in one group and 100 in another group, but they have with 1,200 individuals in their group, they have plenty of data to go ahead and analyze.
Yeah.
There. So they also found some interesting things. The EMS professionals were on average younger and had a higher percentage of males. There were also a slightly higher percentage of white non-Hispanic males in the EMS profession, but it was really, really small. It was 81 versus 80%. Yeah. EMS professionals had a higher proportion of suicides, though, in younger groups. So if you look at the 35 to 54-year-old group, we're talking about 16% versus 10%. And that was very significant. The p-value was less than 0.01. We also had an increase in EMS professional suicides for 18 to 34-year-old group. That was 24 versus 16, but there wasn't a p-value reported in the paper for that one. But I would imagine that group would be significant as well. And then finally, what was interesting, the authors did investigate the method of suicide. There were 3 most common methods reported, which were firearms, suffocation, and poisoning. There was a higher proportion of EMS professionals who listed the mechanism of firearms. That was 57% versus, 67% versus 57%. Suffocation was 24 for EMS professionals versus 21 for non-EMS professionals. Non-EMS professionals did have a higher listed mechanism as poisoning. That was 17 versus 10. However, while some of these differences did sound impactful, none of them were actually statistically significant.
Yeah, and if we could advance the slide, actually advance it to the second one, the table 2 first, which the proportion of deaths due to suicide by age. So the first table were demographic and event characteristics. So these were, and this was the chi-square analysis. Mm-hmm. And then the next one, if you can advance, I don't have control of the screen, to table 2. That'll show the proportion of deaths, all deaths, suicides, a breakdown percentage by age, gender, ethnicity, and then within each of the populations. I'm not sure if we're having trouble. I can't see. All I can see is table 1. Anyway, and then table 3 will show the methods of suicide and the differences that you're talking about, which really aren't different between the two groups. That was starting with firearms and then suffocation and then poisoning. I'm assuming suffocation meaning hangings mostly, or something like that. Or I guess would that include other? There we go. There's the methods of suicide. Okay.
Yeah, so as you can see all the way to the right, they give the chi-square p-values. To be statistically significant, you'd look for something to be less than 0.05, and you can see all of these p-values are well above that.
We've had a couple of mentions. We've had a couple of mentions from the listeners out there about the use of other databases, other data points. Stephanie Bush comments, has any state utilized the National Violent Death Reporting System? Again, one of the, I believe that is part of the CDC and National Center for Injury Prevention and Control, yeah, it is, to explore factors around suicide deaths. And I think in the general population you probably see, but I don't know if it's split out by occupation there. That's another rich site. I was poking around the CDC before coming onto the podcast, just looking at some of the information that's out there about this. So I think it's really important to look at multiple data systems, but it's hard. Getting back to what Dave said, it's going to be very hard to, split that into without having sort of standardized data about our occupation itself. And I think probably National Registry comes to the close to mind for that, to be able to split out into EMT that works on an ambulance for 20 years versus EMT, that is part-time or something. And then a question from Jamie Kennel, knowing that socioeconomic status is a known inverse correlation with suicide in most EMS professional not needing a college degree, and unsure about Arizona. Does the author have an opinion about how much of the difference seen in the study can be related to socioeconomic status level versus being an EMT? So yeah, there's other factors, and that I think is mentioned a little bit. And I don't know if socioeconomic status is, but the other factors are mentioned in the discussion and limitations. So Tony, to your knowledge, other data sets that could be used to kind of tease this data out a little bit more? Or is this, enough to just say, look, it's a problem, and now the next, they do mention in here the next step for research being, looking at confirming their findings and then attempting to identify which aspects of the occupation, whether it's stress or shift work or cultural biases or others, are most responsible for it. I would also say that, how much are people entering the field with a certain degree of PTSD? Are people attracted to this field, already carrying something that makes them, more likely to respond to stress in a particular way? So there's so
Well, and
many.
that's a really good point. I think that one thing to note about studies like this, and all retrospective studies in general, is there's a big difference between causation and associations. We can certainly say that this data and this research found an association between working in EMS and having a higher proportion of those folks who complete or commit suicide than folks who don't work in EMS. However, we can't with these data say that working in EMS caused them to commit suicide. The only way to say that one thing caused something else is to do a clinical trial, and you're going to have a really, really hard time convincing any IRB to put people into one workforce or another to see if they're more likely to commit suicide. There's some times where you're just not going to be able to develop a study that can prove causation. So we have to look at how strong the associations are and make some judgments based on what the data and the tests show.
And the number of studies and the variety of databases that are pointing to this in the same direction, I think, make a case as well. So,
Absolutely.
An important comment that I'd like to read from Greg Fries, which is terminology is really important for us as educators and writers, and I completely agree with this. And I'm not somebody who is very familiar with the terminology surrounding suicide, but he helps us with a resource. Oh, it just disappeared from my screen. I think it's being sent to me by text. But there's a resource. Actually, I'll get to that once it comes in by text, but it just disappeared from my screen. Greg Fries helps us with it. But using, in short, I think using the term, quote, committing suicide is probably not the most optimal way of talking about something like this, and he says he uses died or death by suicide. Here we go. The resource that he talks about, a helpful resource in terms of terminology and talking about writing about suicide, is reportingonsuicide.org. So he said he's chosen to use, quote, died by suicide instead of, quote, committed suicide. As well as a cause of death instead of method of suicide. So
yeah, and in this
anyway,
research, the authors used completed suicide. So
yes,
there certainly is a right and a wrong way to talk about sensitive topics such as this.
Yeah, and it's really great to have.
Can you hear me?
Oh, great! Is this one of the authors?
Yes. Hi, this is Ben Bobrow.
Great. Welcome.
Thank you for joining us.
Okay, thank you so much. I can only stay a minute. I just wanted to tell you how much I appreciate you highlighting this paper and helping just promote and disseminate the discussion. I have listened to a lot of the comments. They're all really great comments. And, I just want to help refocus people. It's easy to get, and we did this when we did the study, it's easy to kind of get off into the woods on all these things that we want to know and we wish we know and we should know, but right now it's really, really difficult to understand and to sort of quantify these things. This was a very basic study. It created so many more questions than answers for sure, and I think you guys have already touched on a lot of those questions. In my mind, the main point of this paper is to call out that we need better data on this topic. And we used, this was really a shop project, I called it, with my students. We had no, we asked this question and discussed it, and we had no good way to answer this question with any reliable data. So we started to scratch our heads. Well, how could we get sort of at a tangential way, how could we get at this answer? And what we did was very, it was a hodgepodge of, trying to answer this question. And we did the best we could, and we tried to be as honest as we could in the limitation section that, a lot of this stuff we just aren't sure about. But what I can tell you is that at every decision point, every decision branch we had to make, we tried to be conservative on our estimations. And what I believe is that what we came up with is a conservative estimation, and what I believe the real true burden of this problem may be far, far higher for multiple different reasons. And I just want that to really be the take-home message, I hope, is that, where there's smoke, there's fire. And what I hope this will spur others to do is to try to work together. What I believe we really need is some type of reporting system that's more robust than what we have. And again, I'm just thrilled that you are talking about this, and thank you to Hillary and EMS World and Dave Page for doing this. I'm sorry, I think Hillary sent me the invite on Friday, so I wasn't really, prepared to say much else, but those are kind of my general comments.
Well, this is great. We really, really appreciate you coming on. And since this is a journal club, we do like to do a little bit of both, right? We like to kind of discuss the research and how to evaluate research. And that's why you hear, people piping in and saying, well, which database should we use, and what types of, and what are some of the limitations, and how to read the literature. But then, like we were saying earlier, the bottom line then is, okay, sometimes things are, this is an important topic, and sometimes we have to say, okay, but if given the limitations, this could, as you said, likely be an underestimate. And so not only does it on one hand call for more research and a living database, a registry, or whatever, but it also says, okay, but in the meantime, we also should be maybe doing something about this, or at least using the already known factors that are associated with completion of suicide, which you mentioned in the discussion. I think the discussion session is so important for people to read. And, we brought up, and I think Tony at the end of his article noted some resources, which we're going to read at the end of this podcast. One that's not there is the Code Green campaign, which is codegreencampaign.org. That's it's a first responder-oriented mental health advocacy and education organization that was started in 2014 by a group of EMS professionals. So, all of these resources now are out there. So I think we want to do a little bit of both when it comes to a topic like this.
For sure. And I think it's a great discussion. By the way, we came up with this methodology through looking at, because of course when we went to the literature, there was almost nothing on, certainly nothing recent on completed EMT suicides. So we what we did is we went actually to the law enforcement literature, and there was some good papers on that, and written by some folks that used this mortality odds ratio, and that's where we that's how we sort of modeled this after that, and that's sort of where we went with this. But I hope that this spurs more research. By the way, my students are carrying on with this line of research now, looking at some national occupational death data, trying to get a larger snapshot. But like someone said, and I agree with this, each of these studies seems to point in the same direction, and it's hard to quantify the burden of this, but I sure believe, and especially experientially, and the people I've talked to, I sure believe this is an issue, and likely, sadly, a really, really big issue. I'll tell you, when we presented this paper at our state EMS council meeting, there was about 70 people there, and I think every single person stood up and said that they had lost one or more close colleagues to suicide.
Oh yeah.
And it was like this. It was really staggering. Every single person in the room, it had impacted them. So
that's an interesting study in and of itself. Anyone who knows, someone who has committed suicide, and then people in EMS versus not. A comment from Anthony Gurn, who was typed in. We'd mentioned that people who have retired, something also most likely, again, underrepresented, are those that left the job, started another career, and couldn't escape it, and then took their own lives. So they probably aren't in the data. So, like you said, I think this is, could be an underrepresentation.
Yes. Thank
so
you.
the retirees are not there. I'm sorry, go ahead.
But first of all, congratulations again, and
yes.
Wonderful that you're looking at this. I think in the state of Minnesota, Chris Calkins had looked at the death registries inside the coroner's office for anybody committing suicide, and he had a hard time. He just defined it as anybody who was ever certified by the state of Minnesota as an EMT. So the logical next steps do seem like we should be thinking about registries and classifying occupational injury or death or near miss in one spot, so that there aren't multiple registries to try and keep track of this. I'm just curious about your feeling in terms of what there's a whole bunch of people on this call that are very smart, very interested in helping. How do they either do their own research around this or participate in the research that you're doing?
It's a great question. One of the things we've been thinking about and even talking about is holding perhaps a consensus conference around this topic, and we're hoping that folks like NHTSA would be interested in helping hold a conference like that. So, I think a next step would be to develop a white paper for, I have my own ideas of how this could be done, but they're probably not the best ideas. And I really think this is where you get, you get people together in a room that have different expertise and different vantage points, and are really, could help develop a model for collecting robust data, not just sort of, self-reported data, but robust data. I'm always hesitant to use the word mandated, but, some system where we could really have a reliable measurement tool. And I think it makes sense to me that it would be a national thing, because why should we just track this in certain places? It doesn't make any sense to me. It likely impacts people everywhere. And
Sure.
So we're hoping to move towards, and this is just sort of our current thinking, and move towards, we are doing more studies now, but they're going to have the same flaws or different flaws as this, but really, large vision would be to move towards a consensus conference where we develop a white paper and a model towards, what could be done on a national scale to report and track and these events.
And a follow-up then, I don't know if you saw the work done in Melbourne by Ambulance Victoria they had 6 suicides in 1 year. And so they have been extremely proactive. They're very research-oriented, and had been trying to determine, is this a chicken and egg piece? So for us that love research, we often need to re-clarify that correlation doesn't mean causation. So perhaps the correlation here between EMS folks and suicide isn't necessarily that the job of EMS causes us the stress that's then that perhaps is affecting this, but perhaps people are drawn to this profession who enter it with some mental health issues already, and then don't find that that healing or satisfaction or needs met. And not to say that stress and exposure to traumatic stress may not actually be causing this. That's very possible, but I just don't know anybody who proved that, unless you've come across that in your travels. We don't quite ever seem to get to that real understanding of what if the event, if a particular large event or a critical event or cumulative events have been really the ones that are affecting this.
Well, that's because I suspect, like a lot of wellness and behavioral health issues, it's multifactorial, and it can work in multiple different ways. It can be, like you said, some sentinel event, or it could be, multiple daily, insults, and it's also complicated because a lot of EMS professionals, at least in Arizona, and I suspect other places, have a military background, and there's clearly an association between military service and stress and PTSD and some of these other issues, and suicide. And so, it's multifactorial, it's complex, but that doesn't mean that that really underscores the need to measure these things and track them, and then move towards figuring out what are some of the possible interventions that could be effective at helping mitigate these things early on, and then even helping people when when they are in real trouble. And how do you identify those people, and all those downstream issues that are really, really important. But it all starts with a data tool, because they say you can't fix what you can't measure, or you can't fix what you don't measure.
I love it. I think that's so powerful. We saw an article in England that measured it particularly asked paramedic students in their first few ride-alongs whether they were having symptoms of stress and thoughts of suicide. And at the moment where they're fairly new and they haven't been exposed to that level of stress or trauma or events, that even without a sentinel event, like you said, they did report very high levels of discomfort and thoughts. And so that's the closest I've seen. But you're right. What do we measure? And the folks in San Antonio, I thought, did a pretty nice job of looking at police officers, and the M550 is a scale that looked at particularly some neurotic behavior that could be contributing to ill health that had to be investigated. That was another scale that we tried to apply to paramedic students, and had some success in identifying some students coming in. But
hey, one thing I'm thinking that I will tell you, I'm sorry to interrupt, but it comes to my mind that I have seen the studies with medical students, and certainly a different population, but still a population that's involved in taking care of people and kind of critical, taking care of sick people and stress and shift work and things like that. Medical students, when they first enter their training, are not significantly different by surveys from the general population as far as depression measures and suicide, but they, by the time they complete their medical school undergraduate training, they are significantly higher risk of both depression and suicide. And so that kind of speaks, against at least that population is a certain, predisposed to this going in. It really does seem to be the general thinking, I think, with medical training, is that it's something about the training. I don't know what part of it. It's probably, again, multifactorial, but it's not, people change. It changes people.
Yeah.
And so
Wow, that's powerful stuff.
That is powerful
I
stuff.
completely agree. Dr. Williams, Brett Williams, did a nice study showing empathy levels decreasing during paramedic school. And it would seem like there's a psychological impact to simply becoming trained. And a comment from one of our listeners was, people in our profession tend to seek help less in general than the general public would. We don't try to reach out and help.
For sure. I agree with that 100%. I think that's one of the main issues. And that's actually also, I think, one of the biggest opportunities. That's something that with awareness and dissemination and cultural shifts and mindset shifts, that's something we can change. And I think that may be our biggest opportunity to help people. The other thing I'll tell you is that, we're always looking for these next great discoveries and, whether they be technology or drugs or devices, what's the next great thing we're going to help people. I strongly believe that our next greatest opportunity to help our patients is actually help ourselves, to make ourselves stronger and more just more empathetic. Basically, we give ourselves the opportunity to do our work and our jobs the way we want to do it, the way we set out to do it. And I think about that's really one of our greatest opportunities in medicine.
That's super powerful stuff. Again, trying to think about how research can help inform those steps and make us healthier. If you think of culture of safety and sort of being able to at least identify an issue, go to the root cause, try and make it less about blaming the individual or their lack of ability. At least, I'm very encouraged by what's happening with Ambulance Victoria, because they did implement a heads-up checkup, which they are doing as an interventional research project, I hope. So the intervention of this heads-up checkup in which the community would say, it's okay for you to go home, it's okay for you to take a day off or a few hours off if there's a child that is sick or has a piano recital, or you're just simply exhausted and don't really think your head is in this game. Then we care about you as an individual, and we're going to take action based on that. I think the culture around EMS today is, if you called up your dispatcher and said, I'm just feeling a little stressed, can I take a break? There'd be a bit of laughter, and they'd assign you a few transfers so that you can, quote unquote, take a break. So it is the cultural piece to how we approach mental health, and the stigmas that surround it are just as powerful in my mind.
For sure. And I think it's actually one step more challenging than that, because I think so many of us don't even understand or realize in the moment how we're feeling. We don't even recognize it. The scenario you gave is that someone at least recognizes they need a period of to pull back and to focus on themselves. But so often people don't even realize why they're suffering and why they're underperforming and in pain and just not doing well. They don't realize the connection between their how they're feeling mentally and their thoughts and their physical wellness.
Yeah. And, somebody brings up also bills that are passed. There was a California bill that was passed recently. It had to do with EMTs being on duty during their, during a break, an organized break. And it just made me think that there's also other factors associated with the job that are not related to exposure to suicide and stressful calls, but also related to how you're treated. And are you treated as a member of the healthcare profession? Do you have a sense of belonging? Are you an outsided, for lack of a better term. We have two other people on the panel and only a couple minutes left, and I'd like to see if Mike Tegman has any comments. And then Krista's on here also. We can unmute you. I know you had a couple of important resources to mention. So, Mike, did you have anything to add to this discussion?
I do have one. I have a few thoughts, but I'll share one since I know time is tight. the Institute for Healthcare Improvement has been doing a lot of work over the last few years on the subject of joy in work, and they have some early but solid evidence that indicates that joyful healthcare providers produce better, tangible, measurable clinical outcomes in the patients they care for.
I love it.
I love it too.
Happy people.
In addition to, in identifying stressors and preventing suicide, in my mind, having the conversation move all the way to, can we provide the opportunity for people to be joyful in their work, and can we use leadership strategies and work schedules and the data that you're discovering with your work here and other data to try to help build organizations where not only are people resilient but also happy.
That's great. And Anthony comments, suck it up is an ugly philosophy. I completely agree. I think, educators would completely agree with you, and everybody on this panel would as well. Krista, are you able to unmute? I see you as a panelist, but I don't see that you're unmuted. Krista had made posted something earlier. Oh, I can see you now. Can you hear us?
Yeah. Can you hear me?
Yeah, great. Welcome. Can you, did you have any comments or questions for the author?
I do. First of all, thank you guys so much. What an outstanding conversation for a very obviously complex topic. And certainly thanks for allowing me to chime in here. A couple things. One of the co-founders of the Survivors Network, which was originally started for crash survivors from the air medical transport industry, but we sort of changed our philosophy to, survivors of working in the air medical transport industry and EMS and those types of professions in general. So it's, thanks for sending out the website to the resources, because, I think that suicide really is sort of, as was mentioned earlier, just the tip of the iceberg. When you look at things like PTSD or PTSI, substance abuse, addiction, I think grief is a huge issue in our industry that is sort of, hard to measure and hard to address. Things like the second victim experience when people make mistakes. And so, what we've all been talking about is sort of addressing this from lots of different angles, and I think that that's spot on. The one thing I did want to mention was in my day job, where I'm the risk manager at MedTrans. First of all, the destigmatizing of the mental health issues is huge. So trying to do that with our new hires. And then in the medical transport industry, we found some really good success with trained peer support teams. And then trying to streamline access to clinicians, professional clinicians that are qualified to manage EMS professionals, because we certainly are a different breed, I think. And at the end of the day, it really does come down to the fact that this is so challenging to measure. But the last point I want to make really quickly is that if you look at the human factors analysis and classification system model that Dr. Scott Chappell and Dr. Doug Wigman put together, it's based on the Swiss cheese model, and the sort of second layer up from the pointy end, preconditions for unsafe acts. The mental and physiological state of the operator is, a large component of that layer. So in terms of arguing this point to, leadership and the people that provide funding for these types of initiatives, it really does go to safety. As to Mike's point earlier, which was fantastic, if our clinicians are, happy and have joy in their lives, they're certainly going to do a better job with patient care, and it will be, safer according to this model. So that's my 25 cents worth.
Wow, that's a lot of 25 cents worth. There's a lot, of great things. Wow, I love that, the correlation between the Swiss cheese model and then the mental health and awareness of the provider. And if you'll shoot us the reference there, I think it'd be great to pair that up with what we're doing. But fantastic, great job.
Absolutely.
Yeah.
Thank you.
We have a point from Max, I think that's important. Looking at a paramedic textbook, mentions of suicide in the well-being of the EMT. He didn't see it, at least in the textbook he was looking at. And maybe we're not being honest with our students. And I do think also that goes to the educator materials and how we're teaching this. Again, not doing this, okay, today we're going to talk for, we have 15 minutes of time and we're going to show you word slides on, on suicide, and that's it, rather than having a conversation like we're having right now, rather than integrating it throughout. I think those kind of things are really important. So
and
any last
the vocabulary to discuss these things is so difficult. People think that by discussing it, you'll cause the paramedic student to actually, attempt it, or that, there's very little awareness and understanding about how to manage this. So absolutely, and it all starts because, people like Dr. Bobrow and researchers start to say, let's give this some measurable, quantifiable, or at least even if it's qualitative, especially if it's qualitative, data to say we have an issue. And kudos to them for doing that. Yeah,
that's great. Any final, it's top of the hour, so any final thoughts from Tony? We've been quiet out there. Any final thoughts from you on this?
I just want to again congratulate the authors on doing this work. This is really important. I think it's important to our field and for our providers, and it was difficult work, and I just want to congratulate you on getting it done and getting it published.
Dave?
Oh, I think that we're smarter together than we are separately. And just looking at the list of people who logged in, we have such great talent. I think we need to be able to solve this together. So I like Dr. Bobrow's approach to perhaps having a summit and a white paper and seeing if we can't get more heads together so we can prevent our peers and our friends from despairing to that degree and get some better health.
Yeah. And in the meantime, at the end of Dr. Fernandez's article, you can note that there are many resources available for those that are struggling with suicidal thoughts. So please pass these on to students and providers. The National Suicide Prevention Hotline, 800-273-8255. And then there are those that are dedicated to first responder helplines. You can check those out at Tony's article, EMS World. Journal Watch, Safe Call Now is one of them. The National Fire Council's Share the Load is another. And of course, we mentioned the Code Green campaign and the Survivors Network-aeromedical.org resources. Thank you all for joining us for this incredibly important topic. A reminder that Education Research Podcast is coming up Friday, January 25th, 2019 at 10 a.m. Pacific, noon Central, where we are going to discuss peer teacher training for health profession students, a systematic review of formal programs. This is in British Medical Journal. This is a free open access article, so you can look it up ahead of time. And if you want to present an upcoming article, you can email Dave Page at dpage@emsed.net. Thanks all for joining us. See you next time.